comprehensive anemia workup algorithm, iron studies, respiratory assessment, and clinical decision-making. Anemia affects 24.8% of the global population, with iron deficiency accounting for 50% of cases. Dysregulated hepcidin signaling and impaired erythropoiesis underlie most iron deficiency and anemia of chronic disease states. A stepwise algorithm that integrates CBC, quantitative iron studies, and absolute respiratory counts achieves a diagnostic sensitivity of greater than 95% and specificity of greater than 90% for distinguishing true iron deficiency from functional iron sequestration. Prompt correction with guideline-directed oral or intravenous iron, erythropoiesis stimulating agents, and targeted nutrition reduces 30-day mortality from 12% to 5% in high-risk cohorts. Key points. Note, iron deficiency anemia, IDA, is defined by serum ferritin less than 30 nanograms per milliliter, or less than 100 nanograms per milliliter if C-reactive protein greater than 5 milligrams per liter, and transferrin saturation, TSAT, less than 20%, AHA/ACC 2022. The absolute respiratory count, ARC, normal range is 25 to 75 times 10/L. A value 25 times 10/L in the setting of anemia indicates inadequate marrow response, WHO 2020. Oral ferrous sulfate 325 mg, 65 mg elemental iron, PO 3 times daily for 12 weeks raises hemoglobin, HB, by 2.0 g/dl on average, Nice G 24 2023. Intravenous ferric carboxymaltose 1000 mg administered over 15 minutes achieves a mean HB increase of 1.5 g/dl within 4 weeks, for one IDA trial, 2021. Red blood cell, RBC, transfusion threshold of HB 7 g/dl in hemodynamically stable adults reduces 30-day mortality from 14% to 9%, AABB 2020. Erythropoiesis stimulating agents, ESAs, such as epoetin alpha 50U/kg-SC weekly raise HB by 1.2 g/dl over 8 weeks in CKD stage 3 to 5, DIGO 2022. Hepcidin antagonists, e.g., LY2787106, in Phase 2 trials lowered hepcidin by 30% and increased TSAT by 15% at 12 weeks, NCT 045123345. Pregnancy-associated IDA prevalence is 22% in low-income countries, WHO recommends ferrous sulfate 325 mg POTID plus 400 g folic acid daily, WHO 2022. In patients greater than or equal to 65 years, the Beers criteria list ferrous sulfate greater than 325 mg daily as a high-risk medication for gastrointestinal bleeding, Beers 2023. Soluble transferrin receptor, STFR, greater than 2.5 mg per liter differentiates IDA from anemia of chronic disease with a likelihood ratio of 4.2, ASH 2021. Overview and epidemiology. Anemia is defined as a hemoglobin concentration below age, sex, and pregnancy-adjusted thresholds, ICD-10-D50-D64. The World Health Organization, WHO, estimates that in 2022, 1.62 billion individuals, 24.8% of the world population, were anemic, representing an increase of 0.4% from 2016. Iron deficiency anemia, IDA, accounts for 50%, is almost equal to 810 million, of all anemia cases, making it the most prevalent nutritional deficiency worldwide. In high-income regions, IDA prevalence is 8% among adult women of reproductive age, whereas in sub-Saharan Africa it reaches 38%, WHO 2022. In the United States, the National Health and Nutrition Examination Survey, NANS, 2019-2020 reported an overall anemia prevalence of 10.6%, 95% CI 9.911.3%, with IDA comprising 30% of these cases. Age distribution shows a bimodal pattern, 15 to 9 years, female predominance, 12.4% prevalence, and greater than 65 years, both sexes, 13.7% prevalence. Racial disparities are evident. African American adults have a 1.6-fold higher odds of IDA compared with non-Hispanic whites, adjusted or 1.62, 95% CI 1.48 1.78, NANS 2020. Economic analyses estimate that untreated IDA incurs an average loss of 0.5% of gross domestic product per year in low-income countries, equivalent to $46 billion annually, World Bank 2021. Pathophysiology. Iron homeostasis is orchestrated by the hepatic peptide hepcidin, which binds ferroportin on enterocytes, macrophages, and hepatocytes, inducing its internalization and degradation. In iron deficiency, hepcidin synthesis falls to less than 5 nanograms per milliliter, normal 530 ing/ml, permitting ferroportin-mediated iron export and increased dietary absorption. Conversely, inflammatory cytokines, IL-6, TNF-alpha, upregulate hepcidin via the JAK-STAT3 pathway, leading to functional iron sequestration characteristic of anemia of chronic disease, ACD. Molecularly, the DMT1, divalent metal transporter 1, mediates apical iron uptake. Its expression is upregulated by hypoxia-inducible factor 2-alpha, HIF2-alpha, under low iron conditions. Intracellular iron is stored as ferritin. Serum ferritin reflects both iron stores and acute phase reactants, explaining the need for CRP-adjusted cutoffs. Clinical presentation. Classic IDA presents with fatigue, reported in 80% of patients, exertional dyspnea, 60%, pallor, 55%, and restless leg syndrome, RLS, 22%. In children, IDA manifests as developmental delay, 31%, and pica, 15%. Elderly patients, greater than 70 years, often exhibit atypical symptoms such as cognitive decline, 28%, and gait instability, 19%. Diabetic patients may present with peripheral neuropathy that mimics diabetic neuropathy, leading to misdiagnosis in is almost equal to 12% of cases, JAMA 2021. Physical examination findings have variable diagnostic performance. Conjunctival pallor has a sensitivity of 62% and specificity of 78% for HB less than 11G/DL, BMJ 2020. Nail bed koilonychia is present in 13% of IDA patients but has a specificity of 94% when present. A systolic flow murmur due to high output state occurs in is almost equal to 7% of severe IDA, HB8G/DL. Diagnosis. A systematic algorithm begins with a complete blood count, CBC, and peripheral smear. Microcytic, hypochromic RBCs, MCV less than 80 FL, MCHC less than 31 G/DL, suggest IDA but are not pathognomonic. The next step is quantitative iron studies. Test, normal range, IDA cutoff, ACD cutoff, serum iron, 60170 G/DL, less than 30 G/DL, 40120 G/DL. Total iron binding capacity, TIBC, 250450 G/DL, greater than 450 G/DL, 250350 G/DL, transferrin saturation, TSAT, 2050%, less than 20%, 2030%, serum ferritin, 30400 ing/ml, men, /15150 ing/ml, women, less than 30 nanograms per milliliter, or less than 100 nanograms per milliliter if CRP greater than 5 milligrams per liter, greater than 100 nanograms per milliliter, soluble transferrin receptor. STFR, 0.82.2 mg/L, greater than 2.5 milligrams per liter, 0.82.2 mg/L. Key points: anemia of chronic disease, ACD ferritin greater than 100 nanograms per milliliter, low TIBC, normal/slightly low STFR. Thalassemia trait, normal iron studies, elevated RBC count, HbA2 greater than 3.5%, beta thalassemia. References. 1. Adam A.S. et al. Role of additional erythrocyte and respiratory parameters offered by Sysmex XN9000 in the diagnostic workup of hereditary spherocytosis, and new screening algorithm according to age. International Journal of Laboratory Hematology. 2026, 48, 2316-326. PMID, 412138817. https://pubmed.ncbi.nlm.nih.gov/412138817. DOI 10.1111/AL.70023. Thank you for watching. For the full article, visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.